Hello, my name is Ravi Vij. From My Cancer Haven, and today I have with me Dr. Guru Subramanian Guru Murthy, Assistant Professor at the Medical College of Wisconsin, who is going to talk to us about Revumenib-based therapy for acute myeloid leukemia. Dr. Guru Murthy has been with us on a podcast in the past on the topic of BPDCN, so I'm glad to have him back for this more contemporary topic now that Revumenib has been approved. Welcome.
Thank you, Dr. Vij. Appreciate this opportunity, and it's always great to be a part of this effort.
Just to lay the context, so what is menin inhibition? Obviously, Revumenib is the first of perhaps several drugs that will be approved in the future that are of the class of menin inhibitors.
Yeah, so it's definitely a very important mechanism in the leukemia biology that has been trying to be studied for several years, and now it has gained a lot of interest because now we can target this pathway with a specific oral inhibitor. So it depends on the type of the leukemia that we are talking about. At least at this point of time, there are two subsets of leukemia where this menin pathway seems to be upregulated. One is actually patients who have KMT2A rearrangement, and the other is patients who have a NPM1 mutated AML. In these patients, the HOX-A-MEIS1 signature seems to be a key factor in driving the leukemia genesis. And menin inhibitors are specific drugs that are able to go ahead and bind and selectively inhibit this pathway, thereby leading to control of the leukemia and hopefully promoting differentiation into normal cells. Um, Currently, there are menin inhibitors that are in development and also that are studied and approved at this point of time, primarily focusing on KMT2A rearranged patients and NPM1 mutated patients. But there is increasing amount of research that is going on, which is trying to establish if there are other subsets of acute leukemia that is not having KMT2A rearrangement or NPM1 mutation, where this menin pathway is still overactivated, and whether they could also be target for menin inhibition. Those are all ongoing studies, and hopefully we'll get to know more about it in the upcoming years.
So, how common are the two targets that you just mentioned? The KMT2A, otherwise, I guess, known as MLL, and NPM1.
Yeah, so definitely variable incidence based on the age of the patient. So if we look at MLL rearrangement or KMT2A rearranged disease, younger patients tend to have more of that. For example, like 80% of infant ALL do have this rearrangement. 10 to 15% of ALL patients generally have this rearrangement, and about 4 to 10% of AML patients also tend to have this KMT2A rearrangement. In contrast, if you look at NPM1 mutation, it's one of the very common mutations in AML patients. About one third of AML patients do have NPM1 mutation. So NPM1 mutation, apart from AML in an acute leukemia setting, is not that common. We don't see that often in ALL, but usually most AMLs, if we have at least some form of a driver mutation, we do tend to see some of the mutations such as NPM1 mutation in that situation.
So obviously, what we're going to discuss next is some of the data that came out on Revumenib at the American Society of Hematology meeting in December of 2024. The drug has recently been approved by the FDA. So before we review the abstracts, can you give us a little overview of the lay of the land as to what we have learned about Revumenib before the ASH meeting?
Yeah, so it's a great advancement in the field of leukemia, I would say. It's actually the first in class oral selective menin KMT2A pathway inhibitor that is actually approved for treatment of adult and pediatric patients with relapsed or refractory acute leukemia that harbor a KMT2A translocation. We got this approval in November of 2024. There are a few studies that have really demonstrated the safety and efficacy of this drug, which we'll be hopefully discussing in the next upcoming minutes. But the most important study of interest is actually the study called Augment 101 study. So it's a phase 1/2 study, multi-center study, open label, where they actually tested single agent revumenib at different doses to actually see the single agent efficacy of this drug to begin with. And Even as a single agent, the drug was leading to CR/CRh rates of about 22.8% and a durability of response of about 6.4 months in this patient population. And many of the patients were also being able to bridge to allogeneic stem cell transplant, which is one of the standard of care for this patient population. So looking into all these results, this drug did get FDA approved back in 2024, and it's currently used as one of the standard of care agents. And that actually is, at least to start with, as a single agent. And there are many studies that are investigating combination therapies with revumenib at this point of time to even improve more upon the efficacy and try to also improve on the safety.
So let's review the studies. I guess the Augment 101 was the pivotal study that led to the FDA approval. So could you give us a little idea about the trial design before we review the demographics and the results?
Yeah, definitely. So it's an international study. It's an open label study where patients with KMT2A rearranged acute leukemia were actually investigated with single agent revumenib in this study. The study basically had a total of 116 patients who were evaluable for safety and about 97 patients who were evaluable for efficacy. The study gave revumenib to all these patients at Q12-hour dosing, and the dose was adjusted based on concomitant strong CYP3A4 inhibitor because there are some interactions between revumenib and the CYP3A4 inhibitor drugs. The primary endpoint of the study for the phase 2 design was CR/CRh rates and also safety, and it had other secondary endpoints that were also looked into, such as the overall response rate and other outcomes as well. So basically, the efficacy population looked into about 97 patients with centrally confirmed KMT2A rearranged disease who had at least more than 5% blast in the bone marrow biopsy.
And so, what are your comments on the demographic of the population accrued? What are the highlights?
Yeah, so it's a big study for a rarer population of patients. So overall, like I said, 116 patients were available for safety and 97 for efficacy. So if we look at the distribution of disease, predominantly 80% plus patients were AML, about 12 to 13% were ALL, and the rest were mixed phenotype acute leukemia. Many of them had relapsed disease. About 17 to 19% had primary refractory disease. Majority of patients had multiple different lines of therapy in the past with a median prior line of therapy of two. About 40 to 50% of patients had more than three prior lines of therapy. And with venetoclax being so commonly used in acute leukemias, particularly AML, it is important to look into prior venetoclax exposure in this patient population. About 62 to 63% of patients actually had prior venetoclax-based therapy, and about 47 to 50% of patients in the study had a prior allogeneic stem cell transplantation also. So it just explains more in detail about how much of a hard to treat patient population they had at the beginning of the study.
So, what are the top line results?
Yeah, so the important ones are actually the efficacy and then the safety. So if we look at the overall response rate, which basically includes CR, CRI, CRH, MLFS, we actually put together have about 63 .9% of patients having a overall response. If we particularly look at CR and CRH, the more important ones that are important for regulatory approval, that is about 22.7%. The CRC rates were about 42.3%. And importantly, if we look at MRD negativity in patients who achieve CR, CRH, or CRC, it is anywhere between 58 to 61% based on local assessment. So I think it's very well reflective of the fact that the drug, even as a single agent, has good amount of activity, and it is able to even produce deep responses in some of the patients. And importantly, like I said, bridge to transplant is another part that we often try to actually get these patients to. About 33% of patients even got a transplantation after being treated with this therapy.
And how durable are these responses?
Yeah, so durability is another factor that we have seen with this agent. So median duration of CR/CRh was about 6.4 months. The median time actually that is taken to achieve the first response is actually anywhere between 1 to 2 months with this agent.
And how well is this agent tolerated?
Yeah, generally well tolerated because it's an oral regimen. Most of the times, patients did not have any major adverse events. There are two class One important class adverse event that we need to always be cautious about when we use a menin inhibitor, which is differentiation syndrome. And sometimes it's related to the potency of the menin inhibitors, also based on some preclinical findings. So, differentiation syndrome, as we are aware of from other diseases like acute promyelocytic leukemia and AML who are treated with IDH inhibitors, basically where the patients do tend to develop a cluster of symptoms that is really happening because of differentiation of leukemic cell into a normal cell. So in this study, about 26.7% of patients had differentiation syndrome. Some of them had grade 3 and some of them had grade 4. And also the other side adverse event that we need to keep a watch on is actually QTC prolongation, which happened anywhere between 29% of patients to 44% based on the grade. But again, all of these are primarily in the context of what has been studied in the clinical trial. And most of these generally are manageable because most of the times QTC prolongation can be mitigated by minimizing the other QT prolonging medications that usually these patients are taking. And then also differentiation syndrome, we have more awareness about that at this point of time. So steroids and hydroxyurea are important treatments to prevent it and also to treat it. So I think both of these agents are also being widely used at this point of time to minimize the risk of differentiation syndrome. Overall, well tolerated from a safety perspective also.
So for some that may not be as well versed with differentiation syndrome, what are the clinical manifestations of the syndrome?
Yeah, so sometimes it can be very asymptomatic and sometimes it can be floridly symptomatic. So many of the times what we start seeing is actually increase in the white blood count, increase in the neutrophil count, which are really indicating towards myeloid differentiation happening. Along with that, the patients can have multiple different symptoms like fatigue that is worsening, weight gain, rash. Sometimes if it is severe, sometimes we can even have symptoms like shortness of breath, sometimes fevers. Many of these are non-specific if it particularly does not happen altogether and if it happens at separate time points. One has to have an increased risk, increased awareness about this condition so that they are able to recognize it early and also intervene early so that it doesn't become a severe differentiation syndrome.
So another abstract with some preliminary data that was presented at the American Society of Hematology with revumenib was this combination therapy study. Could you just give us a little introduction to this study?
Yeah, definitely. I think this is another study that is basically just explaining how potent this agent is and how it could even be more potent when you actually combine it with another regimen on the backbone. So this study is called the SAVE study, which was a single center study at MD Anderson. They had their abstract results that were presented at a couple of ASH meetings. Basically, it is focusing on patients who have relapsed or refractory KMT2A, NPM1, or NUP98 rearranged acute leukemia patients. These are patients for whom we know that the menin pathway is already activated. And this study actually tested a combination of revumenib along with venetoclax and oral decitabine cerazuridan. So it's a completely oral regimen because currently we have been using a hypomethylating agent and venetoclax either as an IV plus oral or oral plus oral regimen in patients with relapsed refractory or newly diagnosed AML. What this study is trying to do is keeping that hypomethylating agent and venetoclax as a backbone in this patient population for whom the menin pathway is activated. It's also adding a menin inhibitor. So it's a triplet regimen. The advantage of being a triplet regimen is it could be potentially effective, and more importantly, all of these are oral agents. So revumenib is oral, venetoclax is oral, and oral decitabine is also incorporated into it. So it's a very innovative study. They have investigated that at MD Anderson. Again, heavily pretreated patient population. Majority of them are adults. About 15% were between the age group 12 to 17 years in the study. Median prior lines of therapy was 3, and majority of the patients actually had KMT2A rearranged disease, followed by NPM1 mutated disease and NUP98 rearranged disease.
And what did they see in this study?
Yeah, the results were very exciting. 33 patients were studied, and overall response rate, what they found was actually 82%. 27 patients actually out of the 33 responded. CR/CRh rates were actually 48%, and CR rates were actually 39%. So definitely appearing to be even numerically higher compared to what we had seen with single agent. But again, not trying to do any cross-study comparisons, but just trying to understand that different studies have different contexts, but the numerical values are very interesting with the study. Same way, just like what we saw with the Augment 101 study, patients who do achieve a response do tend to have deep response. MRD negativity by multiparameter flow cytometry was as high as actually 65% for the all the responders. For patients with CR/CRh, it was 88% MRD negativity. And then patients, about 39% of them were actually able to go to transplant, and then they were also able to continue revumenib as a maintenance therapy after that.
I guess this study at the moment may not have as much in the way of practical application because it's not FDA approved combination. But obviously, that's the way the wind seems to be blowing. So we'll talk about where you see it going in the future. But just the bottom line of these two trials, what would you like the takeaway message to be?
Definitely, I think revumenib is a new development in patients with KMT2A rearranged disease, and it is currently FDA approved. The Augment 101 study has shown that this drug has good single agent activity, deep responses in responders, able to bridge patients to allogeneic stem cell transplantation, and importantly, it was safe and tolerable also. So I think it is already establishing a new standard of care for this patient population, and future studies will actually try to build upon the efficacy and safety that is already established with a single agent through this Augment 101 study. The SAVE study is an example of what potential studies are coming up and how their results are basically looking to improve the results of menin inhibition. And what the SAVE study focused on is a regimen of hypomethylating agent venetoclax along with a menin inhibitor, all three of them being oral agents. And what that also showed is actually in a heavily pretreated patient population, it is associated with high rates of responses, safe tolerability profile, and also being able to be serving as a bridge to allogeneic stem cell transplantation. So overall, definitely heading towards combination therapy in this field.
So the thing is, now this drug is available. Where do you see it being used in your practice in the immediate future?
Definitely. So it is important to understand some of the differences between the menin inhibitors. The current only approved menin inhibitor is revumenib. It is approved in the KMT2A rearranged acute leukemia space. If I have a patient with KMT2A rearranged disease who is receiving a standard of care therapy, that would be the predominant approach to go to with revumenib. There are other menin inhibitors that are in development, which is actually looking into the other space, such as NPM1 mutated space, if it is being used as a single agent. And then if it is being used as a combination, many of these menin inhibitors that are in development, not FDA approved yet, those are all looking into different combinations also. So menin inhibitor in combination with frontline intensive induction therapy or with azacitidine and venetoclax studies are ongoing. Menin inhibitor in the relapse space as a single agent, we already have approval in patients who have relapsed disease, combination of menin inhibitor plus other backbone agents that is also ongoing as clinical trials. And for patients who actually do undergo allogeneic stem cell transplantation, there is also role for menin inhibitor maintenance after transplant. So this is also being studied. So I think if a patient has a menin sensitive disease, based on their individual chromosomal translocation or the gene mutation, there definitely seems to be a role of having a menin inhibitor at multiple different phases of the disease. The important part is at this point of time, we have approval as a single agent. Hopefully, we'll have more results and approvals coming up with combinations in the future, and that's probably where I would anticipate this to be used in the future also.
So if you had the option of using this in NPM1 mutated disease in the relapse setting, is this something that you would use at first relapse? Is it something that in all patients, or is it something you will use selectively? How do you see this being adopted in the NPM1 population, since that is the bigger, uh, bucket?
Definitely, yeah. I think the approval for NPM1 mutated disease is still not there yet. I think we'll have to wait for that approval to come. But if, let's say, menin inhibitors in general, if they have approval coming in for NPM1 mutated disease, I think the first space where we'll actually see the approval is actually in relapsed refractory NPM1 mutated disease. So generally, as you can imagine, NPM1 mutation is actually generally considered as a favorable mutation in AML. Generally, most of these patients do tend to have good responses with frontline therapy with or without transplant. And if those patients relapse, then in that situation, there isn't a standard of care therapy. Most of the times we want to get those patients into remission and take them to transplant if they are transplant eligible. If they are transplant ineligible, we at least would want to maintain their remission and improve their survival and quality of life. So I think in that regard, I do definitely feel that menin inhibitor, once it is approved in NPM1 mutated relapsed or refractory disease, it will definitely be incorporated in that setting, and primarily either as a way to get those patients to remission and take them to transplant followed by post-transplant maintenance, or as a way to get them to remission and then maintain their remission as much as possible.
So the NPM can be a mutation that co-occurs with other mutations as well, often FLT3, IDH1, IDH2. So how do you sort through if you have more than one mutation, how are you going to tackle it?
Definitely. I think that's another area where ongoing research studies are hopefully able to give some answers in the future. There are clinical trials ongoing which are combining a FLT3 inhibitor along with a menin inhibitor if somebody is actually co-mutated for FLT3 and NPM1. Similarly, IDH inhibition along with menin inhibition is also a possibility. Again, all of these would hopefully come from results of clinical trials that are currently ongoing, which will inform us in the future about how best to actually combine these agents or sequence these agents so that we are able to target different clones of leukemia that are driving the disease.
Well, I really appreciate your taking the time to educate our audience about this exciting area. I think there will be a lot more that will be coming out, as you said, in this area. And I hope I can draw on you in the future to tell us about the newer developments as they happen.
Definitely. Thank you very much for this opportunity. It's a great time to start the discussion and keep the discussion ongoing as well.
Thank you.